I'm going to be presenting later today an analysis of the Oncotype DX, which is a test composed of 21 genes to determine why it doesn't perform as well after 5 years of treatment as opposed to in the first 5 years of treatment. There's still a significant predictive value of the test after 5 years, but it's much reduced. And we wanted to understand why that was. We are in the fortunate position to have about 1,300 tumours in which the Oncotype test has been done, but we actually have the individual gene data from that, which allowed us to really tease this apart. And what's clear is that while genes such as proliferation, which figure in the Oncotype DX test, continue to predict quite well beyond 5 years, the estrogen receptor module loses its power completely, and in particular two genes, Scooby2, an estrogen receptor, which people are very familiar with, actually reverse their position. So now, in the next 5 years, 5 to 10 years, those particular two genes predict for worse outcome rather than good outcome. So this seems to at least explain why that test doesn't do as well after 5 years. The data come from tumours which were collected from the ATTACK clinical trial. This was a clinical trial of 5 years of anastrozole versus tamoxifen versus a combination of the two. We didn't collect any tumours from the group of patients who received the combination because that was stopped early. And then RNA extracts were created from those and sent to Genomic Health Institute, who created the recurrence score data. Well, there are other tests that are out there. There's the PAM50 ROR test. There's a test which we created ourselves, the IHC4. There's something called the breast cancer index. There's the EndoPredict. So there are a number of different tests. But I think the most important thing that we understand now is that we should, in fact, I think there are advantages, I should say, from creating tests which figure and focus on the first 5 years of treatment, first 5 years when the patients are on treatment, and then the behaviour of the genes in relation to recurrence seems to be quite different after that for some genes. And if we consider these time periods separately, we may be able to produce better predictors than any of the ones that are out there at the moment because they just haven't considered that issue. Well, for the Oncotype DX, there isn't actually an issue because it's all done in one lab. For those tests which are done between labs, and sure, standardization is a big issue, and that's particularly an issue for things like immunohistochemistry, where one is doing quantitative or trying to do quantitative analyses. That will vary greatly between labs. And we do have some initiatives on, particularly for one of the markers, Ki67, an international working party that's trying to improve this comparison for that particular marker. I think there are two take-home messages. One is for prognosis, and that is that looking at these gene signatures, we need to look at them in a different fashion. But perhaps the most important one relates to treatment. What we can see here is those patients that have the higher estrogen receptor message levels show this increase in recurrence after 5 years at the time when treatment ceases and is withdrawn. Now, it's not certain that that is the reason for that increase, but it's very rational that it should be because we know those patients do benefit most from endocrine therapy. And the clinicians have got to decide which patients they will treat beyond 5 years. And those patients may well have been excluded in the past because in general people think they would have had a very good benefit in those first 5 years, that they're at lower recurrence risk. I think the main focus here is main point is to say, don't ignore these patients. They may indeed be the patients that benefit most from extended adjuvant therapy.